Okay, chapter 24, abdominal emergencies. This chapter is, there's a lot of ambiguity in a lot of the complaints that go along with abdominal emergencies. One of the sad things about EMS is the limitations that we do have on the diagnostic tools. And when it comes to diagnosing a lot of abdominal emergencies, it really does take a higher skill set and more equipment than what we have at our disposal in EMS. So we don't always get a lot of answers, but abdominal emergencies or calls for what we refer to as acute abdomens often are a common request for EMS. So we'll discuss a few of those in this chapter here. There's just a few little objectives, of course, on the first page of the chapter, which is 570. It's a multimedia slideshow on aortic aneurysm. And our core concepts to cover in this chapter are going to be understand the nature of abdominal pain, become familiar with abdominal conditions that can cause pain or discomfort, and how to assess and care for patients with abdominal pain. So as you can tell from the core concepts, there's not a ton of specific material here. We're going to touch on a lot of generalities and go from there. So we'll start with an introduction. The abdomen contains obviously a lot of different organs from different body systems, and those organs can be one of really two major types of organs, the solid organs and the hollow organs. These can cause a lot of different confusion when we're determining the cause of abdominal emergencies, because if you look at, even if we look at the page 571, where it actually shows you the difference between the hollow and the solid organs, if you look at the hollow organs, the intestines, they're all over the place. So it really can be very confusing because they cover everything. So a thorough patient assessment is going to be key, and specific diagnoses may not be necessary. The treatment is going to be the same for most of our conditions, and there's really very little variation. So to review a little bit, remember we discussed the region of the abdomen being from the diaphragm and then down into the pelvis. Sometimes they will refer to it as the abdominal pelvic region, but it's really from the abdomen down to the pelvis, and it contains a lot of different organs and organ systems. Primarily in the abdomen, you have the digestive organs, you have a few endocrine organs, and then we also have some regulatory organs and reproductive organs. Those usually get tucked into extra special spots, where we're talking things like the kidneys and the adrenal glands, which cover both endocrine and regulatory a bit. They are in the what's referred to as the retroperitoneal space, so they don't sit in the abdomen proper. When we talk about reproductive organs, we're usually talking the uterus and the ovaries, and those sit actually down in the pelvic bowl. So they kind of sit off in their own little areas. The spleen kind of tucked up behind. The only real major endocrine organ that we think about in the abdomen is the pancreas. Of course, it plays an extremely important part. So here's that picture of those solid and hollow organs. The hollow organs tend to be tubular in nature. So things like the gallbladder, stomach, the large intestine, small intestine, bladder, ureters, urethra, all of those are hollow organs. They have a capacity to break open or burst and then flood the abdomen with their content, most of which the content that they have is fairly intense digestive juices. So you essentially can be starting to digest your own body if you spill your abdominal content. Whereas our solid organs are very, very blood rich. Okay, not that the hollow organs don't have a lot of blood supply, but the blood supply of the hollow organs is around the outsides and the edges, whereas with the solid organs, the entire mass has a significant blood supply that runs through it. So when we're talking the spleen, which is specifically a blood and lymphatic organ, you bust a spleen and you could be in a world of hurt. The liver, the same way, pancreas, kidneys, all very, very important. So we bust those, we have the chance to bleed, as opposed to busting a hollow organ where we have the chance to digest ourselves. So the peritoneum, if you remember when we talked about the chest cavity, we talked about the pleura, P-L-E-U-R-A, pleura. That was parietal and visceral pleura. Well, the same things we have in the abdomen, except instead of being pleura, they're the peritoneum. The peritoneum is a thin membrane, covers the inside of the abdominal cavity as well as each organ. We have a parietal peritoneum, which covers the inside of the abdominal cavity, so on the back sides of your abdominal muscles. And then the visceral peritoneum covers each of the organs, so the little protective coat around the outside of them would be then the visceral peritoneum. Most of the organs of the abdomen are enclosed within the parietal peritoneum. A few lie extraperitoneally, so I talked about that. We talked about actually the retroperitoneal space. The retroperitoneal space is the kidneys. A little bit of the pancreas and the aorta lie in the retroperitoneal space. And then we also have, or behind it, and then we have the bladder and part of the rectum lie inferior to the peritoneum because it sits down in the pelvic bowl. So if we do this kind of cross-section here and look at the torso, you can see that the blue line that runs, I think you can probably see my pointer here, but we've got this kind of blue line that runs along right here. That represents the peritoneum, and that peritoneum is kind of the surrounding, the parietal peritoneum surrounding those organs there. So you can see what's in, what's out. And then obviously the things that sit down here in the pelvic bowl. So you got, in this case, the urinary bladder, vagina, uterus. In conjunction with the uterus, in most cases, you also have ovaries and fallopian tubes. You have the rectum and a small amount of the large intestine or the sigmoid colon back here that feeds the rectum. And then, of course, your greater vessels, which you have the aorta and the inferior vena cava here. Most of the rest of this stuff, though, lies within. So you kind of see how it all stacks up there, the liver up there at the top. When they show you the spleen up there, it's in relation to where the liver is positioned. The spleen is not actually within the liver itself. It's on the other side, the left side of the body, in relation to where the liver is at. So the gallbladder tucked up inside of the liver there, the stomach, and the pancreas kind of sits back there. So our abdominal quadrants, remember, we use the belly button or the umbilicus as our point of division. If we draw horizontally across the umbilicus, you have the uppers and lowers. And if we draw vertically through the umbilicus, we have rights and lefts. Remember, it is the patient's right and left. So we have the right upper, right lower, left upper, left lower quadrants. So the epigastric region actually is that sits kind of up between, right underneath your xiphoid process, above your stomach is what the epigastric region is. So to talk about some types of pain we may run into, we have visceral pain, and visceral pain originates from the visceral or visceral peritoneum. There's fewer nerve endings that allow only for diffuse sensation of pain, and these are usually referred to as dull or achy or sometimes colicky style pains. So when we're talking visceral peritoneum, remember this is the covering around those organs, and that covering isn't well nerveated, but it can start to sense a little bit of discomfort there. It's not highly specialized, and that's why it becomes very difficult to describe and pinpoint. So that colicky or the intermittent pain may result from distension or the contraction of a hollow organ. So let's say you've composed your diet of mostly cheese for about a week. You may start to expect yourself to have some colicky style pains as you start to get things distending, such as because you can't expel certain fecal material. So you may have some severe distension of your intestines. Persistent or constant pain often originates from a solid organ. So what that is saying is with a persistent or constant pain that usually stays about the same, that item has swollen. So we'll say, for example, the liver. We'll say the liver, which is a solid organ, has swollen. It stays swollen, whereas a hollow organ is going to expand and contract and expand and contract depending on what the system is doing. So if you're digesting something through your intestines, they're going to expand a little bit as the bolus of food comes through, and then they shrink down a little bit as it passes on. So that means that you kind of have this pain that comes as it expands and goes as it contracts. So that's why you tend to have this intermittent pain in the hollow organs, whereas you'll have the persistent or constant pain in the solid organ that doesn't expand and contract. Parietal pain. This originates from the parietal peritoneum, and many of these nerve endings allow for specific sensations, often referred to as a sharp pain, and is usually severe, constant, and localized to a very specific area. So parietal pain is going to be the abdominal cavity covering. We also have referred pain, and referred pain is a perception of pain in skin or muscles at a distant location. So the abdomen has so many different systems, it has so many different innervations. These nerve pathways sometimes overlap, sometimes as they get to the spinal cord, and that pain is actually sensed in a different location than it actually is. The number one example we have of this is people with gallbladder issues, people with cholecystitis, which is the medical term for inflammation of the gallbladder. People with cholecystitis will tend to complain of right shoulder pain. And with right shoulder pain, people may start to be thinking, well, that may be chest pain, or they'll think that it's an orthopedic problem, a musculoskeletal problem. Whereas if you start talking to these people a little bit, say, well, how's your abdomen? Well, it kind of hurts too a little bit, maybe over in the right upper. What did you eat? Well, I've been eating a lot of greasy fast foods, maybe drinking a little more alcohol than normal. And have you ever had problems with your gallbladder? Well, they tell me I have, but I haven't really known that for sure. And that's where asking a few more questions can maybe start to help you pinpoint this down and say, we really don't have a shoulder problem. We have a different problem going on here. So specific abdominal conditions we may run into. Appendicitis. Many people may have dealt with this before. I think this used to be a much more prevalent problem than it is these days. We have much better sciences and medications to help ward this off. But it's an infection of the appendix. An appendectomy is usually what ends up happening for this person. It is a persistent right lower quadrant pain, and the pain is often initially referred to the umbilical region. So they may start to complain of pain around their belly button, but then as time goes on, it migrates down into that right lower quadrant. If you get that rupture of the appendix, very sudden, severe increase in pain, and then sometimes it will even relax and you'll start to not have that pain. But then the abdomen starts to get flooded with contents of the intestines, and this is going to cause a severe peritonitis, or a inflammation of the peritoneum, that blanket that covers the entire abdomen, as that content is spilled out there. There's a couple of commonalities we see with appendicitis. Number one, something called McBurney's point, which is right along the crease of the leg almost. If you would reach from basically the top of your hip bone to about where the crease of your leg and the beginning of your pubic region is, right in that general vicinity there is where you typically will talk about having some pain at McBurney's point. And the other thing about it is a lot of times people with abdominal pain will have what's referred to as rebound tenderness. So if we take our hands and we go and fill in that right lower quadrant region and we gently press down with our fingers, yeah, it kind of hurts, but when we let our fingers off and let it take the pressure away, that patient complains of extreme increase in pain, and that's called rebound tenderness. So it's not as much pressing on it that hurts, it's actually letting go of it that hurts. Peritonitis. this is an irritation of the peritoneum, usually caused by there being some sort of a foreign material in the peritoneal space. In most cases, when we hear of this kind of an isolated incident, somebody has a problem. Maybe they have a problem with a hole that's developed from inside one of their organs to outside of that organ and is spilling content. Maybe there was a penetrating injury, there was a something's burst, or recent surgery. So the parietal peritoneum is very sensitive, especially to acidic substances, which, remember, most of what's in the digestive tract is very acidic. We don't have a lot of alkaline. It's mostly acidic. The irritation causes involuntary contraction of those abdominal muscles, and it comes with abdominal pain and rigidity. So you go and you put your fingers, you try to palpate across their abdomen, and it is firm as a drum. That can be a sign of peritonitis. Sometimes we will associate that with a GI bleed, where that patient is bleeding into the abdomen, and that may be the case. Like I said, hard for us to determine without any other diagnostic tools. But sometimes it's just the pain and rigidity, or they'll do something that's called guarding pain. And when they're guarding, they actually tense up their own abdominal muscles when you go to push on it because they know it's going to hurt. Cholecystitis, again, this is the inflammation of the gallbladder. It's often caused by a blockage of that outlet by gallstones or cholecystolithiasis. The cholecysts or the stones themselves are usually caused by a combination of fat and calcium. Will typically form together there and cause these stones. These symptoms are often worsened by ingestion of fatty foods and or alcohol is the other one that's common. And the signs or symptoms, again, will be sharp right upper gastric pain, or right upper quadrant or epigastric pain, and then pain referred to the shoulder, typically the right. And when you say the right, usually kind of behind the shoulder blade or the scapula. So that's the typical MO with that. Pancreatitis. This is inflammation of the pancreas. It's common in alcohol abuse, and it sometimes is the first sign that somebody is developing diabetes. The signs or symptoms are often very nonspecific. We'll have just upper, usually left epigastric pain. Sometimes it will be referred into the back or the shoulder, but usually these people are very, very sick. So a lot of nausea and vomiting and weakness, and these people feel very, very flu-like in many cases. A GI bleed, gastrointestinal bleed. This is a hemorrhage within the lumen. Remember, the lumen is the inside of the tube. The lumen of the GI tract can be anywhere from minor to severe. In fact, most of us probably at one point or another have some minor GI bleed. That blood eventually exits. It needs to go somewhere, and that's either going to come out the mouth or it's going to come out the rectum. And in many cases is painless because unless there's a major rupture, they may not even realize that this is going on. It's just kind of like bleeding ulcers. When people have bleeding gastric ulcers or holes in their GI system from highly acidic gastric juices, this can be, maybe a dull burn, kind of a heartburn sort of feel to it, but it, for most cases, doesn't feel extremely painful. So now, when you're leaking these fluids, and if it leaks all the way through, if it somehow burns through, you're going to develop some very severe pains and some peritonitis, or some inflammation of your peritoneum again. But GI bleed, very, very common. They have a very, very characteristic smell. And it's more so when it's a lower GI bleed and they've had more time to digest it and work it through the system than it is with the upper GI bleeds. There are a couple other things that kind of go along with it. The dark tarry stool that's often maroon or black, and that black or tarry stool is called melena. They may have frank blood from the rectum, from a hemorrhoid, so they have bright red blood coming from the rectum. If it's bright red blood coming out, that usually means it's right there close to the exit, right close to the rectum and the anus. They may have some vomiting of coffee ground emesis, which is kind of another characteristic sign that goes along with GI bleed. When we talk about people having a coffee ground emesis, usually that means they have a digested blood. That's digested blood is what gives it that coffee ground look to it. And very, very common. So if you hear them even speak of that, or you see that, you should be very strongly suspicious. Vomiting of frank blood, again, they're vomiting bright red frank blood. That usually means it's fresh and it's just right close to the actually entrance in this case. So, and then the pain can be anywhere from very little to very severe. These people can and will get shocky on you. So they'll get tachycardic, they'll get lightheaded, they'll get eventually work their ways into to hypotension. Abdominal aortic aneurysm. Now, remember, if you will, the aorta is your largest artery in your body. If you transect the aorta up in your chest, you bleed to death within about 30 seconds. You don't have a much better chance when it gets into your abdomen. It's still a very large artery. And an aneurysm is the weakening of the walls of the aorta. So sometimes these walls will weaken and then some blood will be diverted and it actually starts to separate those walls of the aorta and it starts to tear them apart. The more it tears it apart, the weaker it gets, the weaker vessels start to bulge because it's still the same high pressure, just doesn't have quite the tension to retain it. And then eventually can either start leaking or start to rupture. They may even have a complete transection. A transection would be when it was ripped completely in half. So this is not a good deal. There are people that run around with abdominal aortic aneurysms and are unaware of it, but they'll often complain of having a big tearing-like pain in their abdomen or in their back. Palpable abdominal mass, possibly pulsating. So if you run your hands across somebody's abdomen, it feels pretty, in most cases, feels pretty consistent across the whole thing. But then maybe when you get to the abdomen right around the belly button, or from the belly button up to the xiphoid process, you might be able to feel, oh, there's something right in there. And you may even put your hand on it and feel it very strongly pulsating. Now, with that being said, thinner people sometimes it may seem that they have a large pulsatile mass there. You got to remember there's less to push through. So if you just kind of feel a little pulse in there, generally not a big deal. But when you really feel it, then that's potentially an issue. And then you can have the possibility of inequality of the pedal pulses, where you may have one leg that's pink and one leg that's pale. Depends on where that aortic aneurysm is. It may be right along where we call the saddle, where it splits into the two iliac arteries. One goes down each leg, and it may be ripping only on the right side. And so if it rips only on the right side, it also affects that right iliac artery, and it will eventually become the femoral artery, but that can affect just maybe the right side. So these signs or symptoms: a sudden severe increase in pain can indicate a rupture. High aortic pressure causes rapid internal bleeding. It's going to lead to shock, and then it's very likely that they will have a fatal hemorrhage or exsanguination within their abdomen. Yes, you can bleed all your abdominal content out in your abdomen. You can bleed all your abdominal all your blood content out into your chest as well. So when we're talking abdominal aortic aneurysm, if it rips, there's probably nothing we're going to do for them. And in many cases, if they transect, where they completely rip it, they could be in the lobby of the emergency room when that rips, in the lobby of the trauma center when that rips, and they're dead. They're going to die. That's just the way it is. There's no fixing that quick. If it's a slow leak or something that they've detected, oh yeah, starting to bulge, yeah, there are things that can be done for those people. They can go in and reinforce those. But once it rips, it rips. So a hernia. Now, a hernia in general is a hole somewhere in the abdomen that allows tissue to poke through. So the picture that they show you in the book on 576 is an inguinal hernia. This man has what appears to be a very large scrotum, and this is as a result of part of his intestines have actually protruded down through his pelvic wall and is now really taking up a significant portion of that area to his right of his penis, and makes him look like he has an enormous scrotum. And a lot of that could be actually, by a doctor, could be reduced and poked back through there. But in many cases, these people need something done to keep them from that keep happening, because if those abdominal muscles then start to tense up around that, then they start to strangulate it, and it loses its blood supply. So this can be precipitated by heavy lifting, can cause that strangulation, and in many cases requires some sort of a surgical repair. It's not usually a fun thing. Now, that's not the only type of hernia. You can have umbilical hernias. That umbilical hernia is when your abdominal content starts to protrude next to your belly button. You can have hiatal hernia, and a hiatal hernia is when part of your stomach actually gets pulled up through your diaphragm. So a little bit of your stomach is actually up inside your chest. Signs or symptoms include sudden onset abdominal pain, often following exertion, and a palpable mass or lump in the abdominal wall or in the crease of the groin in the cases of inguinal hernia. Renal colic. This is actually the medical term for kidney stones. This is a severe pain caused by kidney stones traveling down a ureter. And signs or symptoms are going to include severe cramping, intermittent pain in the flank or back, frequently referring to the groin or the urethral meatus, which is where the external opening of your urethra is, so either in the tip of your penis or near the vagina, and then nausea and vomiting. I have talked to many patients who have had both kidney stones and a baby, and women will say that the kidney stones are in general worse than having a baby. Understand what this kind of is really happening here. Number one, your kidneys didn't fully flush out many of the different salts, and maybe calcium, again, that may be a big problem here, calcium oxalate. And so a lot of these stones were formed just from sediment sitting around, and they kind of start to compact together and eventually get broke loose and forced down the urinary tract. So they'll be forced down the ureter, from the kidney to the ureter, and then from the ureter into the bladder. And then in many cases they also then get passed on and try to be pushed out of the body through the urethra. Well, why is this such a problem? If they were, if they were there closer to their typical size, which is, just a couple of millimeters in many cases, and perfectly smooth, they wouldn't be nearly the issue. But to look at a kidney stone up close, it actually looks more like a cockleburr, where it has these little sharp points coming off of it. Well, those little sharp points aren't going to be very nice to the tender mucous membranes and tissues that it's coming into contact with, especially when it's under pressure. So it starts to scrape and scratch and tear, and so that's often what causes a significant amount of pain. Cardiac involvement. Sometimes the pain of a myocardial infarction can produce the nausea, vomiting, epigastric pain, or indigestion. If we're really truly unsure what we're dealing with, if we're debating cardiac versus abdominal pain, assume cardiac, because without other information to strongly support that this is an abdominal problem, we could be talking to a person having an MI that just doesn't have the typical presentation. So let's talk about some assessment and care of our abdominal pain. So there are so many potential causes of abdominal pain. Again, a lot of times we're not going to be able to pinpoint a diagnosis. We can have some good ideas, some high possibilities, but then we may not be able to perfectly pinpoint what it is that is actually going on. So focus your efforts on a thorough history and physical exam, and then identifying any serious or life-threatening conditions that patient may have. So obviously protect yourself from bloodborne pathogens. If we have people that are vomiting or have diarrhea or even bleeding from the rectum, the mouth, the urinary tract, any of those things. Be aware of odors. Like I said, people with GI bleeds typically have a very, very strong characteristic odor. It's hard to explain, but the first time you smell it and you ask your partner, is that a GI bleed? And they tell you yes, you'll never forget it. So you'll always be able to identify it in the future. So determine if the patient's condition is medical trauma or both. So could you have a GI bleed as a result of trauma? Absolutely. You absolutely could have a GI bleed as a result of trauma. And it may be something that you had to do a little digging to come to. Say, yeah, well, I was in an auto accident yesterday or the day before, and I had my seatbelt up high, and it caused me to have some abdominal pain. And now all my stools are dark black. Well, there you go. Something got ripped. So our primary assessment, general impression, ABCs, level of consciousness, all patients with abdominal pain should be given oxygen immediately because we don't know what's getting strangled, what's being denied good oxygenation, and so giving them oxygen, at least a couple liters by cannula, if not non-rebreather, if the patient's SATs warrant it, they look like crap, they feel like crap, is a good idea. So OPQRST, when did it begin? What were you doing? What makes it better? What makes it worse? You have pain upon movement in any certain positions. Certain positions make it better. As a point of reference, most people with abdominal pain want to be in a fetal position, so curled up in a ball on their side. That takes the most pressure off of the abdomen. So it relaxes the abdominal muscles the most, takes that pressure off. Describe your pain. So we're wanting to know, sharp or dull, burning or stabbing. Is it constant? Is it come and go? Radiation. Point to it. Can you point to it? Sometimes they may have to just wave their hand over their whole abdomen because they can't give us a specific. Does it radiate or move? Do you have any referred pain? Do you have pain elsewhere? Oh yeah, up on my shoulder. Describe how bad the pain is on a scale of 1 to 10. Do you have this pain all the time? Is it intermittent? Has it changed at all? What was it the last time that you had this? Also for female patients. Some of us gentlemen may have a little difficult time with some of these questions, but they're pertinent. They're very pertinent. Where in your cycle are you? When was your last period? Okay. Is your period late? Are you having any vaginal bleeding? How is your normal flow, or your heavy flow, light flow? Have you experienced this pain before? Is it possible that you are pregnant, and are you using birth control? Okay. It's almost ridiculous for us to ask, is it possible, are you pregnant? It should be more like, have you had sex in the last 10 months? Because it is possible for a woman to be pregnant even though she's on birth control. The only way it's not possible to be pregnant is if the woman has absolutely no sexual activity. So are you using birth control, and what types? Remember, there are no 100% fail-safe, foolproof birth control. So of course, getting our sample history. In the geriatric assessment, some other things to consider. Decreased ability to perceive pain because their nerves start to break down over time. So maybe the pain is actually indicative of a certain type of emergency. They just don't feel it quite as much. More serious causes of abdominal pain. So that aortic aneurysm is a very real possibility. It's very much more likely to be life-threatening, and it can be complicated by medications. Other things to go along with geriatrics is geriatric patients have decreased GI motility, so they don't move things through the system quite as quickly, and in many cases will end up being constipated, and that's a big deal to them. So on our physical exam, we're going to be inspecting the abdomen. We're looking for distension, or is it puffed out? They look pregnant, and they're not. Is it discolored, or specific discolorations in certain areas, such as right around the belly button? Is there anything protruding? Do we have this kind of weak area that, that's not nice and smooth, that it doesn't go with the flow here? What is this? With our palpation, using our fingertips, going to the painful area last, the least painful area, the area furthest away, we go first. We're going to assess for rigidity, pain and guarding. So is it soft or is it firm? Does it hurt when I press or not? Does it constantly hurt whether or not I press? And then do they tense up their muscles when I try to push on it? Vital signs, get a baseline, and then every 5 to 15 minutes actually, depending on the patient's overall condition. So remember pulses, blood pressures, respiration, skin colors, temperatures, moistures, mental status. So with our patient care, maintain an airway and be prepared to suction because there's very good likelihood this patient's going to vomit. Administer oxygen based off of what your protocols are and your oxygen saturation. If in doubt, go high flow. Put them in the position of comfort. Normally we'll put them in the left lateral recumbent position or put them on their left side for airway protection. The reason we do this is, well, there's a couple of reasons. The primary reason why we do it is if we put them on their left side on the cot, then they're going to be facing the squad bench in the ambulance. So if we need to get to their airway, it's easier for us to get to their airway as opposed to on their right side where they're facing a wall. So, and then transport to an appropriate facility. If you have your choice between a hospital that does surgery and a hospital that doesn't do surgery, probably should take them to the hospital that does surgery because this is a good possibility that that's what they need. So think about it for you here. You have an 89-year-old female with a history of diabetes, hypertension, and gallstones, complaining of nausea and dizziness about 20 minutes after eating. What are your concerns with this patient? Well, if we go back and we think about that for a second and look at it, she's got a history of diabetes, hypertension, and gallstones. She's 89 years old and a female. So if she, and the hypertension, there's always the possibility that this is maybe even a cardiac-related issue. So diabetes, well, she's eaten something, so that probably is going to alleviate somewhat in our mind that she's getting hypoglycemic. But she has a history of gallstones, and it's right after she ate something. So I think our leading suspect here is something to do with her gallbladder. So is this an abdominal emergency, a diabetic emergency, a cardiac emergency? Really could be any of them, but I think our strongest suspect is an abdominal emergency. How do we really know? We really don't. But we really have the strong suspect when we say it's 20 minutes after she ate. We would like to ask a few more questions. What did you eat? You know, if there's something greasy and fatty, that even tilts it more towards abdominal. And then what will our treatments be? In most cases, our treatments, unless we have strong reason to suspect otherwise, we're probably going to treat this very supportively. Now, maybe our protocol may say different. Maybe they say, well, it's an elderly person, abdominal history, abdominal pain, and a history of cardiovascular problems, which the hypertension goes with that. They may say treat that as a cardiac patient. And if that's the case, then we have to treat that as a cardiac patient. There's a video on abdominal aortic aneurysm and our chapter review. So abdominal complaints must be treated as serious emergencies requiring transport. Diagnosis is going to be very difficult, but our goal isn't to diagnose. Our goal is to assess and get as good of an assessment as possible. We need to do a thorough history, physical exam, and vitals. Quickly identify any life threats, such as aneurysms or internal bleeding and shock. Now remember, if they have an aneurysm and it's a slow leaker, they can show some signs of shock. But an aneurysm that goes from fine to burst, they're probably not going to show signs of shock for very long before they show signs of dead. Care consists of airway management, which can include suctioning because they have potential for vomiting. Oxygenation, positioning, and transport. Of course, standard precautions is going to be important here, and then include disinfecting equipment. When we have to deal with one of these, if that patient's expelling anything, we have to do an especially good job of cleaning stuff up. There are a lot of infections that occur from the abdomen that we have to be careful with. People hear about E. coli a lot, and E. coli is and actually it's a normal bacteria found within your abdominal contents. So those abdominal organs provide obviously a large number of important functions for the body. Remember, there are hundreds and hundreds of jobs that the liver performs itself. The abdomen can be divided into 4 quadrants, with the umbilicus being the reference point. And our classifications of pain can help us identify certain dysfunctions. whether we're talking visceral, we're talking parietal. Assessment and management always takes higher priority than determining the exact cause of the abdominal pain, because sometimes we're just not ever going to know. But if we do a good assessment and we manage them appropriately based off of our assessment findings, that helps us a lot. Knowledge of the characteristics of specific abdominal diagnoses or disorders can aid in differential diagnosis when assessing the patient with abdominal pain. Care for the patient with abdominal pain should include treatment of immediate life threats, administering oxygen, placing them in a position of comfort, and appropriate transport. Now, this short little chapter that we just covered here can in no way possibly cover everything that there is to know about abdominal problems. We haven't barely scratched the surface when we're talking about things like diverticulitis, Crohn's disease, irritable bowel syndrome, and so on and so forth. There are so many potentials. So some questions to consider. Number one, maybe even before we can get here, when I hear about a new diagnosis, what should I do? So now that Brian's mentioned Crohn's disease or irritable bowel syndrome, what should I do with that? Well, I would recommend that you write it down, and at your next opportunity you look up a certain disease. You may not fully understand everything that it has to tell you, but you'll kind of get an idea of what goes on with it. So what are the 5 signs or symptoms of abdominal distress? Describe the difference between visceral and parietal pain. Describe a condition that may be responsible for each. What is the emergency care for patients experiencing abdominal pain or distress? Name the 4 abdominal quadrants and how are they determined. So our critical thinking question is, you're called to a patient with abdominal pain. He describes the pain as severe and says it has been on and off over the past several days and is becoming severe within the last hour. What additional questions would you like to ask? And in what position would he most likely be comfortable? So additional things we want to ask. We want to know about OPQRST, right? So when did it come on? How long has it been going? Describe the pain, which he's told us is severe, so give us a better idea. Is it sharp? Is it dull? Does it feel like a pressure? Does it feel like a burning? How bad is severe? Is that 10 out of 10? Is that 7 out of 10? So we want the rest of the OPQRST. We want to know what his sample history is. So does he have a history of abdominal pains and problems, or is this the first time he's ever had to deal with this? And in most cases, the position of comfort is going to be the left lateral recumbent.